two, mic check.
I had to have 2 bottles of water for the extra flashes. So I sent Teresa a note. So
Mic
hopefully
check,
she'll be able to
mic
tune in
check.
because she's busy with the new
One,
baby.
two, mic check, mic check.
Maybe it's not my news to tell. It's not my news to tell. I am
One,
too.
two, mic check, mic check.
I think about her all the I'm so happy for
So he was born a week ago. He was born on the 13th. So we're celebrating it over here. She and I have the same birthday. Yeah.
Oh yeah, what's your birthday?
October 9th.
Oh, you're Libra, like
Yeah.
my mom is too.
Yes, ma'am.
Oh, I love that for her. I'm so happy.
Wait, let me call him real quick and see
So
where he
happy
is.
for her.
Oh, he's parking.
Oh.
Okay, he's parking. Ooh, I'm having a hot flash. Good grief.
It is a little warm in here.
Oh, in my office, it's worse.
Really?
Yes. I have the window open,
Yeah.
the air going. appreciate it. Wait, let me make sure I did that. Let me do the worst violator of that. I did not. Good morning, everyone. Good to see you all again for yet another one of our conversations. We're happy that you're here. That would help. Yes, let me start all over again. Good morning, everyone. Thank you again for coming. It's good to see you all again. I see some new faces and I see some familiar faces, so I appreciate you all being here. We're here for yet another conversation in our um, opportunities to bring amazing people to talk to you and to learn from. We're here today because we're discussing something that has been, I can't even begin to say when. I mean, there's no when it began, but this is a concern for all of us on many levels. So I'm really grateful that you're all here to learn, to share, and to make sure that you can support folks who are struggling with gender-based violence. I'm Dawn Walker, Vice President of Communications and Marketing, and I have the honor of serving as your moderator today. Our program, From Harm to Healing, Reframing Domestic Violence Through a Public Health Lens, will bring you vital information and help you understand some of the challenges that folks who are struggling with gender-based violence are facing. Today's event is presented by the Office of the President in Communications and the Office of Communications and Marketing. And I'm pleased to bring greetings on behalf of President Riley, who extends his gratitude and thanks to each of you for joining this critical conversation. President Riley champions the connection between public health, social justice, and equity, and his leadership continues to guide Downstate's work in addressing the social determinants of health that shape the lives of our patients and our communities. We extend heartfelt thanks to the Human Resources Department for their work and support through this critical month of awareness and advocacy. Their dedication has been instrumental in ensuring that SUNY Downstate continues to advance survivor-centered initiatives and engagement. Later in today's program, we'll also be joined by Inspector Alan Hayes of Downstate University Police, who will briefly share how our institution supports survivors of domestic and gender-based violence from a law enforcement standpoint. He will join us near the end of the presentation for a few moments. Immediately following today's events, we also invite you to join us for the annual Purple Day photo shoot in recognition of Domestic Violence Awareness Month, and you see Arlene showing the t-shirt. It's a moment for our community to stand strong and together, to show solidarity, and to reaffirm our commitment to ending gender-based violence. According to the Centers for Disease Control and Prevention, 1 in 3 women and 1 in 4 men experience physical violence by an intimate partner during their lifetime. Here in New York City, nearly 41% of female homicide victims are killed in domestic violence incidents. These numbers reflect more than just statistics. They tell the stories of our neighbors, our patients, and loved ones. They remind us that health, safety, and dignity are deeply interconnected. It is through collective lenses that we approach today's discussion, exploring how trauma-informed care, survivor-centered policy, and public health leadership can move communities from harm to healing. In New York City, that work is already underway through initiatives that focus on helping the survivors heal. The mayor's office and the district attorney's office have partnered to develop a near-fatal strangulation education video, now a mandatory training requirement for all law enforcement officers. Alongside this effort, a QR code resource, co-created with survivors, helps individuals access immediate, compassionate information in times of crisis. Dr. Data and Commissioner Sethi can expand upon these initiatives later. Domestic and gender-based violence, often referred to as DGBV, is both a crisis of safety and a crisis of public health. Here in New York City, nearly 41%, I think I said that before, are killed in domestic violence incidents. SUNY Downstate has a moral and professional responsibility to care for those who are harmed, to help those in leading in prevention, education, and advocacy. Legislative advocacy is also advancing through traumatic brain injury, which strengthens protections and support for survivors who experience invisible but life-changing harm. And this fall, the launch of King's Care's Forensic Follow-Up Clinic will provide continued forensic documentation, trauma-informed care, and direct pathways to resources like city family justice centers and the district attorney's office. We'll hear more about those efforts as well. Organizations like College and Community Fellowship are investing in those solutions by empowering women who have been directly impacted by the criminal justice system to lead change and shape policies that prevent and disrupt gender-based violence. With that grounding, I'd now like to introduce the leaders joining us for today's conversation. First, Commissioner Salani Sethi, who leads New York City's Office to End Domestic and Gender-Based Violence. The name has changed, and I love that it engages gender-based violence. Commissioner Sethi brings over 2 decades of experience advancing survivor-centered policies and racial equity across public health and social service systems. Her leadership focuses on prevention, housing stability, and centering survivor voices in policy and practice. Next, Dr. Priyanka Datta, a Downstate alum, proud Downstate alum. Yes, thank you. Is an emergency medicine attending physician and director of the Clinical Forensic Medicine Fellowship at New York City Health and Hospitals, Kings County. She is instrumental in integrating trauma-informed care and forensic documentation into emergency medicine, ensuring that survivors receive both compassionate treatment and justice. And finally, Marlene Peterson, Executive Director of College and Community Fellowship, an organization that helps women and mothers impacted by the legal system to rebuild their lives through higher education. He's a nationally recognized advocate and author. Marlene's work bridges criminal justice reform, education, and healing through storytelling and action. I should note in full transparency that I'm a former member of the board of CCF, but I'm still committed to the work that they're doing. So it's both a privilege, personal privilege, and a moment of pride to have him join us here today. So let's get this conversation started. As we know, domestic and gender-based violence is not only a crisis of safety, it's a crisis of public health that touches every hospital, clinic, and community that we serve. At Downstate, we recognize that addressing this isn't just about the crisis response. It's about prevention, healing, and a shared responsibility of every system that cares for people. Let's begin by grounding this conversation in the real world. For many survivors, the first point of contact isn't law enforcement, it's a healthcare provider. A nurse, a doctor, or a social worker may be the first notice that something is wrong even before the survivor has words to explain it. So as we begin this, I want to widen the lens, and I want to bring the community perspective into the conversation of the work that begins once survivors leave our healthcare systems and continue building their lives. So I'm going to start with a general question for you all, and feel free to jump in. How can healthcare systems better integrate domestic violence prevention and response into everyday patient care, taking into account the justice system and some other challenges that survivors and some victims are facing?
I can start as a provider. Can you guys hear me?
Great.
I actually like this question. I worked yesterday in the critical side of the ED yesterday, and I unfortunately had a DV case where this woman was stabbed by her ex-partner. It seems like he broke into her house. He assaulted her and her daughter, and he stabbed her a couple of times in her hand. And unfortunately, when patients are assaulted or victims are assaulted, when NYPD gets involved, sometimes they don't know who the assailant is. So she was really concerned that she was going to be arrested because in the process of him attacking her, she tried to defend herself and he also had an injury. And as I was chatting with her initially, she was very upset, didn't really want to speak to us. And I think most providers would take her as being combative or difficult to work with. However, with my training, my background, I understand her perspective. She's very terrified. She was violated, her house was violated, her child was threatened, she was assaulted, she's terrified, she's scared, she doesn't know if he's in the hospital as well. She said he was threatening to have people come after her because he's in a gang as well. She was too scared to tell law enforcement this, and she didn't really want to speak with law enforcement because she was worried they were going to use whatever she said against her. Through my relationship with law enforcement, through the work that I do with my forensic fellowship, with the work that I do as a provider, I understand what law enforcement has to offer when it comes to protecting patients, and I have a better relationship with them where I also understand that there is a discomfort that some of our survivors have when it comes to trusting law enforcement. So I was able to speak with her, and I told her, these are my concerns for you. I'm worried that when we do discharge you, your personal safety. She lived in a housing for victims of domestic violence and mental health issues. She was worried about a couple of things. One, she was going to be kicked out of her housing situation. Two, she was worried about her physical safety. Three, he was in a gang, and she was worried he knew where she lived, and he told her he was going to have people to come after her. And she did not know how to handle these situations. And I told her, we have an amazing social worker, and I work closely with the Family Justice Center, and they have a ton of resources we can offer. And also with law enforcement, they have a locksmith program where they're able to have officers come in and change the locks immediately for survivors of domestic violence in real time. So I let her know that these are the options that we have to offer her, and she was willing to speak with law enforcement, but she wanted me to be with her at bedside. So we kind of spoke together, and I think in that instance was really unique opportunity because it let the survivor know that the medical community, we have her back, we protect her, but also law enforcement as well. He did not understand the severity of the situation. The officer did not know the severity of him having access to guns and being affiliated with a gang. So him getting this information was really valuable because they were able to come up with a game plan together. He has access to her keys, and he also has things in her apartments. And she said, how do I have access? How do I make sure he can get his stuff and I'm safe? So we arranged for police escort and all of these things together while she was still an active patient. Additionally, we had our social worker with us at bedside. I let the social worker know her concerns for losing her place in housing and her living situation. Our social workers would be able to work with the community service organization and her case manager to make sure she did not lose any of her housing. And also, I think he damaged the property to make sure that we can compensate her with that and protect her in that way. I think this was very unique because it lets our survivors know that this is the importance of multidisciplinary teams, right? Being able to work with law enforcement, with city organizations like the Family Justice Center, the mayor's office, knowing all these resources as a provider myself, I know what I can give my patients. Additionally, it's important for me to share this with my peers. So when it comes to just not even my residents, but also in situations like this, because sometimes social workers, and I do know that patients do go to providers for care when they deal with domestic violence, but they don't go to medical providers. They go to social workers. They go to Family Justice Center. They go to other resources in the community because they may not necessarily think their physical safety or their medical concerns are their priority. It's their physical safety is their priority. So it's important for us to keep that in mind as well, because when we tell our patients, if they want to go home, if they want to get discharged, I can't hold patients against their will, absolutely not. But I want to make sure if they do get discharged, that they have a game plan so when they leave, they have their social issues addressed, their legal issues addressed as well.
So that's a great example. So I love when we can start with such a great example. But sort of like broaden on that a little bit, right, beyond the ER setting and like healthcare broadly. I think one of the most important things that anybody in any system can do is to understand domestic violence overall, and not just sort of the presentations and the impacts, but also understand that it's a driver into all of our systems, right? A third of families in the homeless shelter system are there because of domestic violence. So many folks that end up in the ER are there because of domestic violence. Even beyond like ER settings, the repeated impacts of trauma have like stress, reactions, or there's other things that you might show up at your physician's office, you might show up at a pediatrician's office. So I do think that basic level of education of like, what are we looking for? And I think like even, small things like Dr. Dada, if somebody comes in with somebody else, separating people before talking to them, right? Once you start understanding that sometimes people are coming in and they're in these sort of complex interpersonal relationships that might be violent, you start being able to make those decisions that allow you to then actually go a little bit deeper with the patient. So I think those are like, in that example, like the thing that I really want to point out that we always tell medical professionals is like when somebody walks in with somebody else, especially if it's two adults, separate them and talk to them, right? Like, and that doesn't happen all the time. And you have that opportunity as a healthcare provider to say, you know what, I have some time, I want to pull this person one-on-one because it's a private healthcare matter, right? And so I think like that's a big thing. I think a lot about beyond education, like resources and materials. It's such a simple sort of thing, right? Whether if you're in a doctor's office, if you're at like an OBGYN or a pediatrician, do you have just brochures about what is domestic violence, right? Some of that passive information sharing can be such an important tool for prevention, because you don't know how many folks like we've worked with, they're like, we hear this all the time where they were in their HRA office looking for benefits and they saw a brochure and started reading a brochure and they're like, wait, I think this might be me, right? And so I think, yes, that, and definitely the collaboration, because when it comes to, being a survivor, it's like your needs are so varied and so complex, and it's often hard to know where to start. And, we always want to start with whatever the most immediate and pressing need is. And so if you can meet one need, you're able to then get to the others. And that's sort of what I'll add to what you already said.
Good morning, everyone. One of the things that I like about the title of this panel is the word reframing. And so part of what we bring to the conversation, as Dawn mentioned, we run an organization called College and Community Fellowship. It's a 25-year-old old organization that started in a women's prison that supports women through higher education and other opportunities for success. The reframing here is that we often don't think about this demographic of people who are impacted by gender-based violence in a way in which they're not only seen as, in a way where they're not seen as people who can add to this conversation. So a statistic, 7 out of 10 women who are incarcerated have experienced gender-based violence. 93% of those, out of those have experienced physical violence. That's important for us to sort of think about, because these folks are interacting with multiple systems, different from men who go inside. When women go inside, often mothers, caretakers, the first thing they think about or ask about is, what about my child? What about my child? And, as an experience just a few months ago, visited, Bedford Hills Maximum Security Prison in New York State, upstate, and, visiting the nursery there, and you see women with 3-month-old babies. It's hard to see, but it's also very important for them to be able to get that connection. Here's where I'm going with it. When we think about these systems, they're varying systems that these women are interfacing with. So they're the folks who have experienced gender-based violence, but they're interacting with, many of them interacting with the foster care system. Many of them are interacting with the educational system that failed them, or didn't see signs, or didn't support them when they were going through things, or when their mother was going through things, or their aunt or grandmother was going through a thing. Many of them interact with social services around the city, HR and these sort of places that don't really understand what they are dealing with at the moment. These women are also dealing with parole and probation, where parole and probation officers aren't fully equipped to get them the support that they need. The reason I bring those things in is with the question that you asked on, you're thinking about the intersecting system that this particular demographic has to face. So imagine having to deal with so many of these things coming home and then go ahead and be successful. Many of them are, we're able to support them, we invest in them, but we also understand that investing in, their better outcomes through higher education, other opportunities for success, we know that we have to provide access to other wraparound services. One system, the major one I can't believe I just left out, is housing, housing instability. So imagine being a person, being a woman who has experienced gender-based violence, is potentially experiencing it, or going back to a neighborhood, a community, or a house where they were, where they have experienced that, that harm, and still having to navigate a successful reentry into society. And then going to parole, checking into parole or whatnot, or probation, or immigration probation now, to bring that into the conversation, and still having to deal with the trauma of having to navigate all these different systems where you still haven't, your life may be in danger. I'll conclude, I think about one of the women in our organization now, we call the women organization members, who we've been providing support for some time now. She's, ambitiously pursuing a vocational license, and she has to house serve in the moment with her child because her children's father keeps finding her. And so because we've been able to interact with other systems, being able to support her and getting some immediate transition, some housing in that moment. But that's just one example of a person who is trying to get her life together, is mothering as best as she possibly can, is trying to get resources to support her and her family, her and her child, but doesn't have housing stability, and is navigating parole and all these sort of systems. I just want to paint the picture of what the weight of what some of these folks are dealing with.
Yeah, that's a great point. I wanted to jump back to something that you said, and Commissioner, I'm going to ask this question of you. You talked about signs beforehand that others may not have recognized. We see it, we know something is not quite right, but sometimes we can't put our fingers on it. But in a circumstance where, Commissioner, your office has been leading a lot of citywide initiatives that link healthcare, justice, and community systems to strengthen prevention and provide support for survivors. How do you ensure that survivor leadership is one? Because, and I'd like for you to define that because I love that phrase. Um, Gets in the space where they can create the resources that provide the services or the ability for some teams to see something is going on.
Yeah.
You know,
Sure.
it's a delicate conversation for people, obviously.
Yeah.
How do you introduce
Yeah.
that conversation?
Well, I think like that's what's so important, right? Like I think given how pervasive domestic and gender-based violence is, like it's literally, turn to your left, turn to your right, somebody's experienced it in the room, right? That pervasive. The fact that we don't talk about it really has so much to do with our own deep discomfort, right? Whether it's our experience, whether it's someone we know. And so how do we sort of address that and think about survivor leadership as a way to give survivors voice and agency over their own experiences and give them that platform to be able to use their experiences to then inform the work broadly, right? Because I think in so many ways that's the gap. The stigma gap is we don't talk about it. So how do we empower people to start talking about it, however they want to talk about it, to whoever they want to talk about it? Because that's what we need to do to really shift that culture, right? And so when I think about that, one of the things that we did at NGBV, which is the short name of our very long name office, is NGBV. One of the things we did in 2018, we actually advocated to create a committee of survivor leaders, which is, rare for a city agency, but something that we were really, really committed to is me and my colleague, Jen DeCarli, who started it. And, we got a group of about 15 survivor leaders that had all accessed our services to then start informing some of our work. They do things, they do public speaking for us, they do events for us. When we redo like an intake form at our Family Justice Center, they look at it first. When we designed our website of resources, they beta tested it, right? And so I think that's like a really important way. And over the years, that has grown to the point where now we can now pay them for their support, which is really amazing. We pay them to go to meetings, we pay them, and so it works in this way of like, A, helps our office by informing the work. They're part of all of the work that we do, any of the roundtable work we do, and any of the other initiatives that we do. B, it helps them build professionally. It's like professional development for them, right? Like they have resume building. They've like worked with our office on X, Y, and Z. Or they've done spoken on X, Y, and Z. A lot of them have started their own orgs and started their own networks, and it allows us to sort of get into communities where we wouldn't be otherwise, right? Really get into that community level. And then the only other thing I'll sort of add when it comes to survivor leadership that I think is important when I think about the next level of it is I also think like so many of us that come to this work also come from our own experiences, right? Myself included. I'm always like, I grew up this work, I do this work because I grew up in domestic violence, right? And so I understand it like from the inside and want to change it from professionally, right? And so I think it's really important to also like be okay with ourselves talking about our own experiences in a way that feels comfortable in professional settings, right? To sort of break down that silo of like, you're the one we help and I'm the one doing the helping. Rather, this experience is so common that we've all been there and we're all kind of in it together trying to push through for different change.
Do you find that people are more likely to open up to you if you share your story first? I would assume that that's the case.
Yeah.
But particularly because we don't know who is affected, right? It can be anyone. We sometimes have an idea in our head who is affected by domestic violence, but many people are not telling, right? And we have to be able to look for those telltale signs. And I think that's one of the things in terms of, sort of identifying what those signs might look like in someone who may be at the top of his or her, because it does happen to men, let's be very frank, someone who's at the top of their organization and they're struggling with domestic violence issues. And it doesn't necessarily have to be physical. It's emotional, it's financial, it's all kinds of stuff. And, the things that we tend to sort of miss out on, and those are the things that we need to be able to tell people to look for very early on in their circumstances. Marlon, you were going to say something?
Yeah, I just want to add on. I want to underscore you, Commissioner, with the Survivor Center. As I mentioned, the women that we work with, what they also have is this concept of playing around with core redemptive power, like to be able to turn struggle into purpose, right? I mentioned at the outset the organization was started in a prison. These women in a prison were needed to figure out a way to get access to higher education. At the time, there weren't a lot of opportunities to do so in 2000, and they came up with the idea, and lo and behold, it's a 25-year organization where we supported thousands of women to go through higher education. When it comes to this same issue here, in the Survivor Center, there's the power in that too, right? I think oftentimes, here's the thing about victimization. I think sometimes with victimization, while there's a need to also understand that there's a process, and sometimes it's a reoccurring process, and there are a lot of residual effects of that trauma in that, that there's also a power that is sort of developed through being able to survive that experience, right? And that they can now, as you mentioned, through the experience, be able to inspire, uplift people, come up with solutions, and not only solutions in terms of inspiring, but come up with policy solutions, right? To be able to shift what the conversation looks like. I think that, oftentimes um, we see our folks, because they've experienced this great deal of trauma, as solely as deficits in need of. And while there is a part of that is absolutely, absolutely accurate and true, they also have a lot to add to this conversation. They know it better than anybody else. They know the nuances in it, that sometimes where an academic study may say this thing, but they can tell you the nuance of what this academic study may have missed. Or sometimes they are the academics and they inform it from a personal lived expertise. I think that's super important to this conversation when we think about ending it, because we're as I said, the title of reframing this is also reframing of who we bring into the conversation.
And that's why it's important to have someone like Dr. Data here on this panel. I know your work at Kings County and through the Kings Care Forensic Follow-Up Clinic. I mean, you're going to be making an announcement soon about that, but it demonstrates how healthcare can serve as both a bridge to both healing and justice for survivors. I'd like for you to talk a little bit about forensic strangulation and what it is when a woman or a man comes into a hospital for care. Again, we talk about the first person very likely being someone in a healthcare setting rather than law enforcement. So if you can elaborate on some of that, I'd appreciate it.
Yeah, absolutely. So strangulation is actually very, very common. A lot of people use the term choking or suffocation, but unfortunately, with strangulation, it can cause a lot of significant damage internally without no external signs of injury. So when I was in medical school, we weren't really taught anything about strangulation. As an emergency medicine provider, we weren't really taught about strangulation injuries. But through the work that I did, and particularly with the mayor's office and the and gender-based violence division of the mayor's office, we've noticed an uptick of people that have had strangulation injuries that they may not necessarily seek medical care immediately, and they have long-term complications. So, for instance, patients that are strangled essentially causes a traumatic brain injury. I'm going to give you some medical background. We have vessels on our neck. When there's external pressures on the vessels on our neck, it decreases oxygen and blood flow to our brain. As a result, our brain does not get the oxygen and blood flow, and that causes irreversible damage to the structures of our brain. So it causes brain death to that. Depending on how long someone is strangled for, they can have symptoms from loss of consciousness to seizures to death. And typically, on average, within 7 seconds of continuous pressure, people lose consciousness. Then about 10 seconds, they have a seizure. And the seizure is due to anoxic brain injury, means lack of oxygenation to the brain. And typically what happens is when these patients get strangled, they don't necessarily know they have significant damage. Because what happens is when you're having lack of oxygenation to the brain, there's a part of your brain called the hippocampus. It's the first structure that's affected, and the hippocampus helps form memory and in chronological order. So as a result, when patients are strangled, and if they come to, they'll say, I was in the kitchen, then I woke up in the bedroom, and I have pain, and I can't really breathe, and it's not really making much sense. And most of the times when I hear these 911 calls is they're not actually calling for EMS, they're calling for law enforcement because they're worried about their physical safety, because the assailant is still physically in the house. And majority of the times they refuse to get medical treatment because they feel like they're fine, they're speaking, even though they can't necessarily breathe comfortably, and they are refusing to see medical providers. And these instances are difficult because, as a paramedic, I'm not a paramedic, but like I've heard from my EMT colleagues, it's difficult to force the patient to do something that they might not necessarily want to do. And I'm a very big believer, to an extent, survivors know what's the best thing, what's safest for them. So I'm not a big believer on forcing anyone to do anything they don't feel comfortable to do. And whenever I speak to any survivor, I always say, because people that are violated, they kind of lose their agency and they lose their power. So when I see them, my job is to make sure that they feel empowered. So I let them know, you know what's best for your safety and what's best for you. These are what I can offer you, but I can't tell you what to do. You know what's best for you. So if you don't want to seek medical care right now, that's okay, but there are some long-term complications that can happen. And that's where the Strangulation Roundtable came into play. Because we understand that survivors, for instance, if it's a mother that was strangled and she has a child that has to go to school and they have to have emergency housing, her priority is probably to get emergency shelter rather than getting medical care for herself and making sure her kid can go to school and her kid's not traumatized as well. So what we did is we created a QR code content, which essentially lets the survivors know what exactly is strangulation and why it's so significant. So we talk about the anatomy of the neck, we talk about the signs and symptoms, the high-risk signs and symptoms. And what I really liked about that experience is we had a survivor come and talk to us about the language that we used. And more importantly, through working with her, she was able to tell me that she's experiencing symptoms that she did not realize was in relation to strangulation. And it helped me realize the language that I use when I speak to survivors. So, for instance, she has memory issues till this day. And she's like, I'm in my 30s. I don't know why I'm forgetting things. And I thought it was just because I'm getting older. But because you said I have strangulation with this history of brain damage, it lets me know that this could be a side effect from it. So as I was able to connect with her with neurology and TBI specialists to help her get outpatient follow-up. But for me, it's important for me to let my survivors know. If you were strangled even 10 years ago and you're having memory issues, it's because of some physical damage that happened to you, and it's nothing physically that's wrong with you, something that you did. It's something that happened to you that we have to make sure that we get addressed. And I think for me, the most important thing is how we empower our patients is giving them education, having them absolutely know to full an extent what the risks are and what happened to them, and also a plan on how we can do to help them to address these complications they could potentially experience in the future.
Yeah, and I just sort of want to pick up on that, right? Because I think what's so interesting about this work with the Strangulation Roundtable is that there's been a danger assessment for intimate partner violence that's been around for 20 years.
Yep.
The number one high risk factor is strangulation, right? Because somebody's literally trying to stop you from breathing. So that's been around for such a long time. But like that next step, this is really taking the next step, right? So when I did one-on-one work, I'm a social worker by training, so I used to do like individual counseling with survivors, and you'd always talk about strangulation being high risk, and they would always minimize for many, many reasons, right? Just because they're navigating their own safety, they're juggling so much, and it's easy to minimize and don't want to admit it. And so I think, to me, it's such a great example of how we've taken something that we've known for a very long time in the field of intimate partner violence, and then partnered with, our partners at H&H in the medical field to really outline what the consequences are in a way that's going to hit people slightly differently and hit survivors slightly differently when they realize, you know what, actually it's not just about the abuse. There's actually physical long-term effects that might impact me and my, and my health going forward. And so I think it's a really sort of beautiful thing of sort of coming at it from a different angle that we hadn't for a long time.
And I'd like to add on to it with strangulation, with how violent these perpetrators are. There have been studies, there have been data that's out there that shows that people that strangle are 10 times more likely to kill their victims in the future. So this is something I also tell my survivors too, is, because unfortunately, there's a lot of social and contextual issues as to why sometimes some survivors may go back to their abusers. And I like to let them know there is absolutely no judgment. I'm not living in your shoes. You know what's the safest for you, because it is dangerous for a survivor to just leave if they know that their assailant has access to their records and things of that sort, their financial issues and all that stuff. So they have to have their own plan on when they're ready to leave. But I let them know they are very violent people and they're 10 times more likely to kill you in the future. Just to let them know that how severe these injuries are, because they do minimize it, because they feel if I'm breathing, I'm speaking, it can't be that bad. But exactly what it is they're blocking your ability to breathe. They're stopping your brain and your body from getting oxygen and the nutrients that it needs. And this is a very violent assault that they can look at you and see. And I've had assailants say, I can see you dying in front of me and I have control over your life. And they let their survivors know that I can kill you whenever I want to, and I can leave little to no bruises and no one will believe you. And I've had survivors tell me this, that they were assaulted and strangled, and their perpetrators and their abusers have told them I can get away with it because I've done it with my exes and I've gotten away with it. And unfortunately, with the legal system, it's now changing because of the work that we're doing. A lot of these perpetrators do get away because the legal system does not understand the severity of strangulation injuries and the long-term effects that happens. And I think that's what's also beautiful with the work that we're doing is we're also trying to change it on that level as well to have, and it's working. The DAs that we work closely with, they also understand the severity of these injuries. So we're trying to help increase the charges as well on a legal aspect to help make sure that if they do decide to go to court, that on my end as a medical provider, I know what I need for medical documentation. I know what's important to make sure that I have all the forensic notes on my end to help the DAs when it comes to prosecution, also to help be the voice for these survivors, right? Because 9 times out of 10, it's very overwhelming, and there's a huge mistrust with whoever they're speaking to. So if they trust me and they want to tell me everything that happened, I'm going to make sure I document it in a way that's advocating for my patients, but also being very neutral and not bias as well.
I can, first of all, when we talked about this a couple of days ago, it completely floored me. We hear about, domestic violence. We often think about someone being beaten up, and we do hear about the strangulation, but the whole piece behind it and the traumatic brain injury would never have crossed my mind. So this was very enlightening for me, and it opens up a whole other element to the conversation. I wanted to touch on something you mentioned also. You talked about people who, and no judgment for people who are going back into their circumstances because there are other things they need to consider. I can assume, Marlon, that you can share some information about that as it relates to the women who are part of CCF. Can you elaborate?
Yeah, I mean, because when you go away and you come back home, you're not coming home to a better situation. Oftentimes, you're oftentimes coming right back to the place you left from. So even if that person, even if your experience with violence, gender-based violence, was a person who lived in your neighborhood, maybe not in your apartment, maybe you don't live with them, maybe they lived in your neighborhood, they lived in your projects, they lived in your area, they're still there. And their friends may be still there, and the stigma of what you experienced still exists. And for what it's now reignited, for what it's worth. And now, in some cases, they may be, they may be related to you in some capacity, meaning like they may be your children's parent or something like that. So there is a relationship you may have to figure out how to navigate coming home from a jail or a prison. And that's and so that's one part of it. The other part of it, I just thinking about this is that when we think about GBV, we often think about in our minds we have somebody who's in their 20s, 30s, 40s, 50s, 60s. We're not thinking about people in their teenage years, particularly now, right? And the way folks can emotionally, psychologically harass and be violent towards people online, towards their girlfriends or boyfriends or whoever it is online, and how that's a different type of trap because you in some cases what you can like not you can may avoid a location. That doesn't mean it's okay, but you may be able to avoid that street, that neighborhood. But this is here all the time. And it pops up anytime, whatever social media app you're on or what have you, or someone sends pictures of you, or now AI, they can create things. So as we're having this conversation around ending gender-based violence, is also being able to sort of look at the ways in which this issue has evolved and morphed with modern times, and also we think about our young folks who are going through a multitude of different changes in the moment, but they don't have this language. They don't necessarily have access to the doctor and the commissioner and whatnot to be or feel comfortable saying that to an adult, but they're dealing with it in themselves. So you think about the end of incarceration, but you think about what leads people to incarceration too. So think about a 15-year-old person who may be dealing with this among all the other things they have to deal with. Wouldn't be so surprised if they also committed something that trauma to hurt themselves, hurt that person, or hurt somebody else that put them in the lockup now. And now they have to deal with that in a place where there isn't the resources to deal with that problem they had in the first place. So I'm just, just not making it hard, but just, part of this is, it's hugely about awareness, right? And awareness of the young people in our homes, in our communities that are dealing with these issues without any sort of language to articulate it with.
I want to switch for a moment to the work that CCF does and its impact in higher education. How does higher education serve as a pathway for women who are coming home, and how does that help them heal when when they're faced with circumstances like we're talking about?
Yeah, for sure. I mean, we have women going from licenses, vocational licenses, to PhDs and JDs who have been inside over the last 25 years. That's amazing. I mean, the level of the level of esteem boosting that it does, just first of all, right? That's a huge part of it. Like they are able to have one of the things that the system, one of the things that abusers do is take away your agency or your sense of agency, where they control you, whether it be that abuser, whether it be the system, the carceral system, it takes away your control. What access to higher education and actually pursuing it does is give you some self-agency. Like, I can do this, I'm good, I'm smart, I can, I can raise my hand in class and do this project, et cetera. I can get this degree, right, and pursue a career in a way that maybe my mother, cousin, uncle, father, whoever never had the opportunity to. So that's the first thing, right? That's sort of intrinsic value that it brings. But also just in terms of the economic impact, right? Where if you have access to higher education, the higher you go, you have access to higher economic outcomes, which allows you to take care of yourself in ways that you may not have been able to take care of yourself also, and not reliant upon somebody staying in a relationship because, well, the finances, right? You may be in a position to take yourself out of that circumstance, or just financially move out of that neighborhood, move out of that project, move out of that city, even take care of your kids better, where you don't necessarily have to rely on that person in any other way to help support your family. And we have an annual graduation every June. We just had our graduation this past summer, and you know, to see what the women have, not only this year's graduates, but to see what the could be had this thing we brought alumni back together, to see the things that they've accomplished. Like, they are running programs, they're running programs in Columbia University and all these sort of places. Like, they are the ones who are the architects of power. Right? That's actually the award that we gave out. I just started thinking about it. But like, they're the architects of their own power, but they're the architects of the power in their communities. The other side of what we do at CCF, College and Community Fellowship, we played a huge role in policy shifts. So we played a role in education and reinstituting Pell and TAP for people who are currently incarcerated. We played a huge role in that. We have a program now called Power, and we actually started our first cohort just a few weeks ago, where women from around the city who have experienced incarceration are now coming up with issues that they want to advocate for or against, right, throughout the New York City, and come up with policy recommendations. And clearly, gender-based violence is one of the issues that some of the women are thinking about. So it's two things happening here. Again, access to higher education, that again, self-esteem boosting for themselves and their family, and high, potentially high economic outcomes for themselves. But they're now creating solutions for their neighborhoods. That's all. That was always there. What the abuse does is sometimes cloud you from being able to see it, tell you that it's not true. What you're seeing is a mirage. What you're capable of is a mirage. That's not true. You can't do that. That's what that does. And what they're doing is they're breaking a mold with these folks. This is survivor-centered leadership.
What I find very heartening about that is that the women, primarily, most of them, are doing work in the same space, so they can help others get through it. I'm especially proud of our JDs and our PhDs, but I'm equally proud of our BAs, BSs, our social workers, primarily. I'm going to guess that a large percentage of those women who are coming out of CCF programs are in the social work field, helping professions, right?
LMSWs, yes, a huge, significant portion of them are.
That's a shout out to all the MSWs and all of them. Yes.
I'd like to add on to something about higher education, particularly in pediatric patients, because I do work with pediatrics as well, and I unfortunately do see pediatric child abuse. And I think for me, I also am a survivor of child abuse as well, and something that I was taught by my teacher as a child is no one can ever take away your education, right? They can take away your power through other ways, but they can't take away your education. And when I was working with a shift, an 18-year-old girl, unfortunately, she was dealing with domestic violence at home, and she kind of ran away and was unfortunately in a situation where she was being trafficked by a family friend of hers. And she was not willing to, speak to law enforcement, and I respected that autonomy, and I didn't, escalate that. But she was going to community college, and she was kind of at this cusp of, she was a very bright kid. Do I want to go to school, or do I kind of want to continue with what I'm doing? It's not ideal, but at least I'm safer and away from my mom. And, I told her, I was like, listen, I normalize it to an extent. Like, I was in your shoes. I completely understand what it's like to be terrified and to not feel like you're supported at home, but I'm on the other side, right? And what I was taught is no one could take away my education. No one can take away my hard work. You can take away my home. You can try to take that away from me, but the knowledge that I have inside of my brain, inside of me, you can't take that away from me. And I think letting my pediatric patients know that, or even my adult patients, just empowering them and letting them know, like, I went through not extent of what you've gone through, but I have an idea, and I'm on the other side. And there are ways that you can still protect yourself. And your education, I think, is something that we don't really shine light on, but it's something that no one can ever take away from you, and you will have it with you for the rest of your life wherever you go. So it's something that I really like to spread to not even my pediatrics, but my adult patients.
Yeah,
as well.
and I think it's something that we really miss when we talk about gender-based violence in general, that we're sort of getting to finally, which is that one of the most important things you can do to sort of keep yourself safe is be financially independent, right? Financial abuse is in 99% of DV cases that we see, and financial dependence is such a concrete reason why people end up staying in situations that are unsafe and unhealthy. Because obviously it's New York City and we all want to keep a roof over our heads and roof over our kids' heads. And we do anything for that, right? And it feels impossible to leave. And so I think like really thinking about, when we talk about domestic violence, gender-based violence, I think one of the nuances we need to keep talking about is like, yes, it impacts everybody, but how it impacts you really varies depending on your socioeconomic status, your education level, your immigration status, ethnicity, race, like connection to this country, right? Like your access to supports is defined by your identity, right? And your understanding of what help looks like is defined by your identity. And so I think really being able to have those nuanced conversations and think about like, one of the biggest ways we can keep people safe is make sure that they're educated, make sure that they're financially independent. Like I always say, if I end up in a situation, I got divorced recently, right? If it had been abusive, right, I would in a position where I would be able to rent an apartment. I wouldn't have lost my home. I wouldn't have had to like go into shelter, right? And if once that happens, that's when some of the other impacts get harder and harder to kind of undo and unravel. And so I just think that's something that we really really need to keep doing more of. And at our family justice centers, we have economic empowerment programming at all of them, with partnerships across all of that, and I think again work that we're really hoping to grow and kind of continue investing in.
I want to pick up on something you just mentioned. You mentioned immigration, and as you know, this is a huge conversation nationwide. And for the work that you all in the space do, it's critical to understand cultures. How do you engage cultural sensitivity in these conversations?
Yeah, I mean, I think I mean, for a lot of it, we work with a lot of culturally specific orgs. So I think our list of partner organizations is, I think we have over 150 partner organizations across all 5 boroughs, right? So some of it is making sure that we always have, people like Korean American Family Service Center or Arab American Family Support Center to really identify with certain communities and make sure we have those resources available to survivors when they're coming to us, so they can really get support from somebody that looks like them, that speaks their language, that understands them. And not everybody wants that all the time either. Sometimes they're like, actually, no, I don't want somebody from my culture, right? But I think more broadly, it's really important to acknowledge that like this is not a cultural issue. This is not specific to any one culture. This is not specific to any one religion. It is abuse. Abuse is about using what you believe to control you, right? And how do we have that conversation that like, these disparities and people that exploit these disparities, like really talking about gender violence from a lens of power imbalance and a lens of inequity, right? It's about people exploiting inequities that exist in our social structures, and those are across all cultures. What that looks like, depending on what your culture is, it might sound different. The language use might be slightly different, right? The specific examples might be slightly different, but it's the same thing. And so I think really making sure that we're never blaming culture, and also understanding the points of strength in culture, right? And so I always think about of like my own. So I'm South Asian, and so I was recently, I can kind of speak to that more intimately. So I could talk about like what it looks like when people use religion against you in that context, right? But I can also talk about like all the moments that we have communities where people, especially mostly women, come together and maybe have conversations and have their own spaces. And so how do we use those spaces to actually build understanding and build knowledge, right? There's that strength in there. Or there's, to Dr. Dada's point, the culture values education. How to use education in those ways, right? So I think it's always trying to look at both.
I wanted to bring something up to Marlon. And I'm looking here about the intersectionality, and the question I have is about structural inequities that endanger survivors. How can policy better address the concerns and the overlapping barriers that these women face or men face across the board?
Yeah, I mean, I like how you just said, and men, because that's a part of it, right? Is that we don't want to make the assumption that only women are the ones who are survivors of gender-based violence. And also we also don't want to put it into the lens of it's only heterosexual relationships where gender-based violence happens, because there's a significant part of the lesbian, gay community where this also exists as well. So that's just putting that nuance in there. But the biggest thing I think about in terms of the policy level is thinking, as I said earlier, about the way these intersecting systems, how to navigate these intersecting systems, and how that there are traumatic experiences in these systems that can hinder a successful navigation of the other system. So there's a trust value, right? As Dr. Dada mentioned, right? Not only mistrusting of individuals, but of these systems that say they're there to help them. and individuals within these systems who aren't the best equipped to actually help these folks, right? You might call it a bad apple or whatever, but that bad apple can rotten a whole human being when when they don't have the right support at that moment, where they don't feel heard. And that's the biggest thing I think from a policy level, right? And why survivor-centered leadership is so important in the policy conversation. Because what being heard doesn't also necessarily mean that, I have a housing issue, so just give me housing. That might not be the only thing. Where is this located? It might be a part of the issue, not just anywhere where you can live. How does it, is it safe for my son or my daughter or my children or my grandchildren? Because that's also a part of the equation. And then I think also not lastly, but just to put it together, the finances that's required to be able to access these systems. I'm talking about things as basic as traveling from one place to the other, right? We make assumptions about what people can do in these situations. You can just go here, you can go there. Just get just make this appointment over there downtown Brooklyn, and then you can make this appointment in the Bronx, and then you just come back. Like, we make these assumptions about what people can do, and there's also very ableist assumptions that people can move around in a way, just like, I may be able to move around to get to these different things. I mean, policy is about what people need, right? Now, there's clearly, the numbers that's required to be able, the money that's required to invest in certain things. But policy is about what people need in the moment, and that's the nuance. The nuance is where most of the work lies. The synapse in between things that people that our folks are navigating. Because once again, like our folks, when I think about our folks, I think about our folks who've been through the system and those sort of things. You can only imagine the myriad of residual trauma they have to deal with, but also just issues getting your life together, right? Being able to get your life together, an option for you might be to go back with the person that harms you. That might be an option. I'm not saying, we all know that's not the option to take. We all can say that here, right? Where we are of sound mind, of stable mind right now, and there's a level of safety in this space. But that's an option for some people. And we don't want them to choose that option. But often, sometimes they do because of financial dependency and all those sort of things, or just not being able to feel like they can live on their own. I need this person to take care of me. I need this person to what have you. So, I mean, I'll always go to this part when I say about policy. Like, part of our organization I've done a lot of work on the policy level and the nexus between education and criminal justice. And what has made us successful is that we have women who understand the nuance.
That makes it very, I don't want to say easy, but it makes it a lot more manageable to some extent, because there's still all these other elements that they're dealing with. I'd like for you, Commissioner, and Dr. Data, to weigh in on from your perspective about policy.
Yeah, I mean, I think, I have a very flip answer about policy. I'm like, I think it's great. Legal policies are great, but they still only apply to the people they always apply to, and people that they don't apply to, they don't apply to, right? Like, look at all the Epsteins and look at all the, so I'm like, it's great. It's great in terms of legitimacy. I don't know what it really does for people. I'm just gonna be really, really frank. And so
That's why the work of the advocates is so critical.
That's why the work of the advocates is critical, and I think, like, it's meaningful, and it's meaningful to create pathways to justice. I don't think about justice as criminal justice, and I think that that's really important, and I don't think about justice as the criminal legal system, right? I think for me, it's like, when I think about justice is about being able to live a life that's free of harm and free of violence, and a life of your choosing. Like, to me, that's justice, and that's the work that we focus on doing. And I think when we think about this work, it's really, how do we do both, right? Because different survivors are going to need different things. We had a lot of folks coming in saying, I want to go through this criminal justice process. I want to make sure my, abuser is X, Y, and Z. Mm-hmm. And then we also, as Marlon's mentioned, we also do work with criminalized survivors, mm-hmm. right? We know that most people, and I would really expand that. It's not just most women. I feel like most people that end up incarcerated are there because of trauma and experiences of violence somewhere in their past, right? And I think about everybody as criminalized survivors. And so I think, like, that is, to me, what makes the work complicated and interesting and exciting, is that, like, I think where we really want to move it to is to this kind of community-based prevention, education, kind of healthy relationship conversations, right? Because what we see over and over again is that these cycles of violence are intergenerational, and then even more than that, what I always keep saying is domestic violence is a learned behavior. Violence is a learned behavior, and it's mostly learned at home, right? And the reason it's learned there is because that's how people grew up, and we all kind of know those folks that like their own trauma kind of puts them in that mindset of I went through it too, so you can deal with it as well. Right? And that's a trauma response. That is a basic trauma response. And so how do we start thinking about this more in a community way, more in a family way, more in like, and how people actually live and experience these things, and then try to develop tools for that kind of work. And so I think, some of the work that I'm really excited about that our office has been part of, that we're sort of doing in that direction, is that we've started doing community-based healthy education programs for adults and for young people. And so there's one for young people ages 13 to 21, and there's one for people that are 18 and up. And that also, we started working with providers. We work with a provider that works at the intersection of gun violence and domestic violence, working with all like the gun violence response folks, the crisis management system, to provide training on what that looks like, because we know it's the same people in the same communities experiencing violence. And we recently launched in partnership with our friends at the Center for Justice Innovation, a program called Men Rising, which is about engaging, men who are community leaders, especially in the gun violence movement, and also speaking out against like domestic and gender-based violence. So I think like shifting to that kind of response, which is like education, prevention, and intervention all at once, but in a community-based way, is I would call that policy and program development.
That's a good way
That
to
we're
put it,
supposed-
actually,
yeah.
because one feeds the other.
One feeds the other. Yeah.
Dr. Dada?
Yeah, I mean, for me, it's difficult because as a medical provider, I don't think I would be in a position to change policy much. However, I do know I'm in a position of power, and I can use whatever resources I have to try to work and do what's best for my patients. So, being in a public institution, I love being in public institutions because we have amazing social workers that are very creative and know how to navigate the system to give the best things for our patients. So I think that's what's empowered me, is to figure out what I can do with the resources I have to do what's best for my patients, and based off what each patient needs that they have. And I think through partnering with other organizations is really helpful. So for instance, the FJC, they provide emergency Uber funding for folks that need to get emergency shelter or even to go to a doctor's appointment. I think that's really, really helpful. And I think for me as a provider, seeing that survivors of domestic violence get very overwhelmed navigating the system, because it's a very complex system, because it's not just the medical umbrella, it's the legal umbrella, it's the social umbrella. And I think for me, it's realizing there is a need. And I use my position of power to bring that need to my hospital leadership and say, these survivors need a follow-up. They need some type of follow-up. When they leave the hospital and they leave the ER, I don't know how they're doing. I don't know if they're connected to care. I don't know this undocumented patient that feels unsafe going to another institution is going to get follow-up. So I was able to use that to bring this up to my leadership and say, hey, I think these patients would benefit from getting follow-up at an outpatient setting. And through that, I was able to help create this clinic that's able to give follow-up services to these survivors of domestic violence, and we'd be able to get referrals externally from the Family Justice Center, from the DA's office, when they encounter survivors that have dealt with domestic violence and trauma that aren't connected to care. And we'll be able to connect them to care, and vice versa. If I have a patient in the ER that is a DV patient that needs emergency shelter or needs to get a lock changed immediately or needs to go to a doctor's appointment and can't make it, I can connect with my colleagues in the FJC to get them connected to the care that they need. And I think for me, more so than policy, I think it's important to tap into other resources that the city has, because the city has a ton of resources that I don't think we're all taking advantage of. And I think as a provider, I know what the hospital system has to offer, the public hospital system in particular has to offer, and the FJC and the mayor's office, they have a lot of resources that I don't necessarily know that they have to offer. And through working with them, we're able to do what's best for our survivors, right? And I think that for me is what I learned, is the importance of multidisciplinary team. It's because these survivors, they need a team to protect them, right? Not just a doctor. They need a lawyer, a DA, or a social worker to protect them. And if all of us working together, that's the best way that we can make change. And I don't know if that's policy that can do that, or just all just being passionate and just working together and being connected with the resources that we have to do what's best for our patients.
Marlon, did you have, I saw you taking notes. I thought maybe you had something to say.
Oh, I was sending a note to the
Oh,
commissioner.
okay.
But there, I mean, we was passing notes, but no, but there is, I mean, it's definitely connected to this, and I think about it as approaching one the elephant in the room, the one male on this panel, and it's, I'm thinking about looking at the other men in the room, but also this is being streamed, right? Is that it's two things. One is, being an upstander means being able to speak about these things, speak up about it. One is your friends, one is your brother, your whoever it is, be able to, to bring the awareness to your sons, little guys around your neighborhood, but also speak up if you are also somebody who has experienced gender-based violence. I think that opens up, that gives air for people, for younger folks to be able to express what they're dealing with. As somebody who's a survivor of violence as a kid, right? That type of violence as a young person violently at gunpoint, right? As a kid, one of the things I'm thankful I was not somebody who repeated that cycle, but I think it's important for me, for others in this room, to be able to give ear, as I said, to this experience, whether you've experienced it or vicariously experienced it, whether as a harm doer, perpetrator, or somebody who's been a victim of it. I mean, because we're here for around the conversation of ending it, right? And this is all so policy is a part of it. It's all encompassing. It's not just policy, because some people may think, well, just change the policy, that work, fix it. No, right? It's clearly not it, but it's a part of it is that policy, but also these experiences, the storytelling around this informs the policy. That informs the nuance of how we get to to actually end this horrible problem.
And I think, sorry to interrupt, but I think having forums like this, or having conversations, having these dialogues, I think this is what's also important, right? Because we learn from each other, and that way when we speak with survivors, we know what resources we can offer them based off of speaking and having these forums as well.
I have one other question for you, Dr. Data, and then I'll open up the floor for a few questions. For survivors who are hesitant to involve law enforcement, what key steps should they focus on or know about seeking medical care?
Absolutely. So there's two branches I want to talk on that. So one of the things is sexual assault. I definitely want to talk about, because I think a lot of survivors of sexual assault, when they come to the ER, we often offer them an evidence kit collection. And majority of the survivors are like, I don't know if I want to press charges. I don't know what I want to do with this. And I let them know, like, we can collect a kit and you have 20 years until you make that decision. So I think letting them know the extent of what the options that they have, it's very, very important. Also letting them know if there's part of the kits that you don't want to get done, we can absolutely stop that. Or if there's a part where we have to swab, if you'd rather swab yourself, we can absolutely do that. So I think letting survivors know that it's not a black and white situation. We can work with you with whatever you feel comfortable with. I think similarly with law enforcement, I think as a person that grew up in New York, and I personally had a huge mistrust with law enforcement growing up, I understand the concern that survivors have, and I'm very forthcoming with them as well. I say I understand there's a huge mistrust with law enforcement. However, as someone that works directly with the Domestic Violence Division of law enforcement, I know that there are officers that are very, very motivated and really empowered, that want to help the community, and there are officers that actually do care. And just letting them know that there are resources, that when they're ready, that the precinct, you can speak to someone at the precincts and get those resources. And they have patient advocates as well in these precincts. And there's other places that they can go to get support and resources that's not necessarily with law enforcement. And that's where I think our social workers come into play, and they're really, really helpful, because it depends on what the patient wants. Is it safety planning? Is it that they're worried about their physical safety, and kind of seeing what their needs are and then kind of working with them that way? And I think what's unique with the position I had yesterday was I was able to, with the patient's consent, speak with the officers about her concerns and us having a conversation together. And I think being in positions like that, where I can have the patient with me and kind of be their voice for them because they're scared to speak to law enforcement, I think that's another way as well that I can help increase that trust that patients have with law enforcement as well.
Actually, before we do this, Inspector, would you give us a couple of moments to talk about, from a law enforcement perspective, what can be done? And after that, Sean, I'll ask you to monitor the Q&A for me. Thank you.
Sure. So I'd like to start with saying I'm overjoyed to just be in this room, right? Dr. Data just hit one of the most important parts from a law enforcement aspect. First of all, I have to thank everybody in this panel for everything you do in gender-based violence, domestic violence, because by the time it gets to law enforcement, it's too late, okay? 50% coin flip is the chances of somebody who experiences domestic or gender-based violence for being reported. One of the issues is the trust or distrust or the relationship between law enforcement and the community. Being a part of this, being in this room, I don't even want to say I'm a part of this conversation, but this experience of learning from all of these different avenues, being a part of the executive staff of University Police, I've learned so much today, right? So we have a law enforcement perspective, but that's not even an arm in this whole body of an approach to ending domestic violence. This is a finger in the grand scheme of things, and I understand that. The one thing that we try to stress is overcoming these obstacles of underreporting, not just to law enforcement, but to all of these other resources, right? 50% is a horrible statistic. I love the fact what Director Peterson said, the reframing of this conversation. This is not based on a specific population. It's not male, female, non-binary. This is not a relationship, whether it be an intimate relationship or another family relationship. According to the DCJS of New York State, just living with another person, a roommate, constitutes as a domestic partnership, okay? Child and parent is considered a domestic relationship. There is a broader base of what the understanding of what a domestic or gender-based partnership is, that this conversation does not take place unless something like this conversation happens. So overcoming those stigmas, immensely important. I took a few notes. One thing Dr. Data said, strangulation and criminal obstruction of circulation of breath are completely different charges than assault in New York State. So it is so important that that advocacy is brought to light on a daily basis. Wonderful work. Thank you so much for that. The commissioner brought up a few great points. Correct. The criminal justice arm of domestic violence is only a small part of it. I have to give credit to my chiefs for having me as a part of the executive staff. To now, I'm also a part of training and crime analysis, the data aspect of involving me so that I can be here, so that I can take this information, so I can make these connections, so that our patrol officers can bring maybe a more human side to the patrol responses, okay? I've been a part of the New York City Police Department before. I was a part of the University Police. I was a part of the CompStat unit for NYPD, where domestic violence is looked at as a number. We talk about numbers and responses in case dispositions. We don't talk about the human side of whether or not this person's going to call 911 again if something happens to them. Okay, so I don't want to say much more than that. Again, we're just a small part of that, but I just want to thank you for involving us in this conversation. I just want to leave us with this: is that we are all advocates and we're all stakeholders in domestic violence. And the only way to reduce the stigma is to continue to have these conversations. So thank you very much, and thanks for having me here.
Now we'll open up the floor for questions. Anyone? A hand up? Sean will be your Vanna White. Sean?
I actually has two questions. The first question has to do with law enforcement. Do you see or have your experience been that law enforcement is better equipped nowadays as it was, as opposed to 40 years ago, and in helping victims, and particularly your example that you gave, Dr. Dana, and the victim who used a weapon to defend herself and was afraid, because 40 years ago, that was not the case. If you use a weapon, this is based on my own experience in dealing with domestic violence, and I used a weapon to defend myself. And when law enforcement was called, I got arrested too. And what's so ironic about that is that I worked with legal aid at the time. I worked in the criminal defense division. And so we were both arrested, and I was afraid to even call any of the lawyers that I worked for. You know, so I don't know if things have changed nowadays.
I can jump in. Quick.
I'm just going to be one small part. Yes, because first of all, I would not have been in this room if things haven't changed. So again, these conversations are imperative. So one of the things I have for my notes for obstacles overcoming with the problem of underreporting is the fear of the victimizing, the fear of the victim using self-defense or being investigated as a perpetrator themselves. Okay, I'm sure that the commissioner will chime in on this. Through the academy 10 years ago, which was not 40 years ago, 12, 13, 14 years ago, my apologies. Training in domestic violence for patrol officers specifically has changed drastically from everybody has to go if there's any violence to helping to try to determine a primary aggressor. That said, I do think that there's an improvement in the criminal justice system. The Department of Criminal Justice has reframed how police officers are trained on a statewide basis, and again, on an agency level. I think that each individual agency has changed and realized that these conversations and how policing takes place needs to evolve. Has it changed? Has it gotten better? Yes. Is there quite a way to go? Absolutely.
Yeah, and I was going to jump in and say something similar. We're like, yeah, there's still a ways to go, but at least the idea of criminalized survivors is fairly well understood now, right? And I feel like that's a change that's happened in the past like 10 to 15 years, really, about like whether we call them survivor defendants or criminalized survivors or talk about resistive violence. All of those phrases are really common. And I'll sort of highlight two things. I think one thing is our office recently took over a program that provides supports to survivors in criminal court in FY24, and we added advocates that work specifically with criminalized survivors in criminal court and every criminal court in each borough to kind of help identify these cases before they move forward. And also, there's also been, beyond the NYPD law enforcement response, there's a lot of work that's been done with prosecutors and DA's offices on this to off-ramp these cases even if they get to that next step, right? And so, yes, I think there's been definitely progress, a lot more to go.
And I'd like to add on to that, as a provider, I also teach at the NYPD Police Academy. They have orientation. They have like every October and June, they do trainings with their cadets, their oncoming cadets, and particularly with strangulations. A lot of survivors, when they're strangled and they have a seizure, they come across as combative. And law enforcement says they're combative, they're aggressive, they're intoxicated. And I do a lot of education with law enforcement to let them know that physiologically something's happening to them, which is why they're coming across as combative, but they're not in fact combative. So I agree with you. There's definitely a long ways to go. And we're also trying to, be a part of the change by, as a provider, I'm letting them know about the importance of, if you're going to a call and if a patient is agitated in the context of a trauma, it's not that they're being difficult. There could be something physiologically going on that they should think about before they kind of go into action mode as well. Next question, please. And then Michelle.
Hi, good afternoon. Thank you so much for the work that you do. My name is Nicole Sharp, and I lost my mother to domestic violence when I was 15, and I was orphaned as a result. And as an adult, I became an advocate for domestic violence awareness and prevention. I actually started here at Downstate in 2007. And so I'm an advocate outside of Downstate as well. And I had a question. It's a healthcare question. My mom, before she was killed, she was an inpatient because of injuries at least one time. Because after she died and I was going through her things, I read a discharge note from the doctor that said that patient disclosed that she was beaten by her husband with a vacuum cleaner. I wanted to know, is it mandatory? Is it mandatory reporting for doctors when it comes to domestic violence? And also, how can healthcare systems integrate domestic violence and gender-based violence prevention and response with regard to patient care?
Yes, that's a very good question. And to both of you, I'm really, really sorry that you had both experiences. And with losing your mom at a young age, I'm really sorry about that. It's a very good question. So when it comes to adults, if an adult is in an abusive situation, I am not mandated to report that because they have their own autonomy. And like I said, adults tend to know what's best for them. So I can always encourage them. I can always, in those conversations, I express my concerns. I encourage them. I also document it in the charts. And I also make sure when I do discharge them, I give them a ton of resources that they can use whenever they're ready to use said resources. If it's a minor, I'm a mandated reporter. I will have to report that to minors. I think for me, in those unique instances, I'm glad that you brought this up because I actually worked in a strangulation case at the DA where unfortunately this woman was murdered by her ex-husband her ex-boyfriend rather, who had strangled her. But 6 months prior, she actually went to a hospital. She was strangled, she was beat up, she's 24 and she had a brain bleed. And unfortunately, there were so many issues with the chart, but the provider got the history from her abuser. He was actually with her. And she didn't speak at all to the provider, and the abuser essentially told the whole story to the provider. So essentially framed it as she was drinking, and she was intoxicated, and she had a seizure, and she hit her head, and kind of made it seem like it was her fault.
But those are the signs to look for.
Yes,
Right.
exactly.
Taking
Exactly.
control.
Exactly. And that was a very tough case for me to read as a provider myself because several things that went wrong in the chart is strangulation was never documented until she was in physical therapy. And a physical therapist got that history that she was strangled and then had all these symptoms. And then unfortunately, she kind of got lost in that system, right? Where she was discharged. And what was really frustrating is they documented bruises all over her body, they documented concern for assault, and the mother had even called and said, I'm really worried that this man is abusing my child. And for I don't know what happened at that institution, but it was very, very frustrating for me to see. And that for me as a provider let me know that we have a long ways to go when it comes to our documentation and if we're seeing something that's concerning, addressing it in real time. And I think in that particular case, it was a learning experience for me. So when I do teach residents, I go across New York City as well to teach residents. And my Maimonides from every 5 borough in New York City is I bring that as an example. On if you see something is wrong, even if this patient's discharged and you look at the record on an outpatient setting, is don't ignore that. Follow with that patient, give them the resources that they need. And with me, I'm in a unique position where I have the relationship with law enforcement and the Family Justice Center. And if I get the patient's consent, I say, hey, I think this patient's high risk. And law enforcement actually, they have a follow-up where they can actually follow up with survivors in the community and see how they're doing. And that would be a patient that I think would have been beneficial to at least give her resources for follow-up or whatever the case that she may need when she was discharged. Unfortunately, it wasn't at our institution, but I think that you are right. We do have a long ways to go when it comes to being providers and looking at medical records and making sure that we don't miss anything. And it's something that I'm trying to figure out how we can combat and navigate. And the best way that I can think of addressing right now is to go to these institutions and to talk about it and to let them know the importance of documentation on a medical legal aspect. Because working with the DAs, I can see how our poor documentation affects the survivors, how us doing things like writing allegedly is really harmful to survivors. So I always make sure I let my doctors know, whether it's nurses, social workers, even medical students, never use this language. Never use anything that's accusatory. Use exactly what the patient states. And if there's anything that's concerning to you, document it in a way that's not going to make the patient look bad, but also make sure you let your patients know, hey, I'm really concerned. I know you're saying this man's not abusing you, but I'm really worried about this. And you know what's best for you, but I'm just going to give you these resources. Just in case if you want to speak to someone and want to get some help, these are something that you can have to use in the future.
Thank you. I think we have time for 2 more questions.
Hi, everyone. Thank you so much for doing this. Close to my heart. So I had a question. What structural inequities mostly endanger survivors, and how can policy address them? I've known throughout the talk when we started that you've touched on it a lot, but there's such a broad range of what is missing for this situation. And I just came to the realization a couple years ago, as a survivor myself of childhood abuse and also adult, that it seems like it's a full circle thing that somehow, if it happens in the childhood, it's a recurring it's a recurring act. Do you find this with your patients that you see, especially pediatrician and then to adulthood?
Absolutely. I don't know if you guys are about ACEs scores, adverse childhood experience scores, and there have been studies that have shown people with higher ACEs scores have higher likelihood to deal with domestic violence and other types of assault in the future. And I think that's ACEs, ACE,
Okay.
adverse childhood experience scores, and it's something that like I'm a data girly. I love numbers, so it's something I tell my patients as well. And I say, this is a cycle that we are at risk of being a part of, myself included, right? I had a high ACEs score growing up, and I knew that I was taught growing up thinking my husband's going to beat me and my children up, and that was normal. Until I was 16, I went to high school, and they had a DV awareness event where they were giving cell phones to survivors of domestic violence. And that was the first time I heard domestic violence. I was 16 years old. So I think for me, it's just normalizing that to my patients and just being very honest. You know, like I said, I know I'm in a position of power where patients think of providers and doctors like, oh, they have this great life and they don't really understand the struggles that people go through. And I let them know, like, I went through a very tough experience and I know I was at risk. And till this day, I still am at risk of potentially being in part of that cycle. And I make a cognitive effort to make sure I try to break said cycle. And through that is through using resources. And I think one of the things that we don't talk about in DV is therapy. And I think that especially survivors of childhood abuse, and someone that grew up with 2 immigrant parents and don't believe in therapy, that wasn't something that was supported and talked about and encouraged. And I think that letting our survivors know that you are at a higher risk and it's nothing that's you're doing to yourself. It's just the the circumstances and what's normal to you is not necessarily normal and healthy. But when you're constantly around that environment, you think it's normal and it's healthy. And just letting them know that as someone that's been through it, this is not normal and this is not healthy, and you can break this cycle, and you deserve to be in a situation where you feel safe, where you can live your life comfortably and not worry about your safety or your children's safety. And letting them know that it is possible to break it, but it's very, very hard, and to be very, very aware because you have these harder experiences, you're more likely to be prone and think things are normal that may not necessarily be normal. And to have providers and social workers that can speak out and say, hey, I'm really concerned that you're experiencing this behavior, and I think that it's not fair to you to be spoken to in this way or treated in this manner. And when I do see that, is I try to let them know the resources, and I really, really encourage therapy to my patients because I think that for someone to break the cycle, they have to do a lot of work internally to realize how their trauma experience the way that they view the world and move throughout the world. And it's something that you don't necessarily get by your own. It's through working with a therapist, in my opinion, I think is
Yeah,
really, really helpful.
And I also think the other like big missing piece in all of this, right? Because yeah, it's more likely it's not inevitable, right? It's not
Mhm.
inevitable, and I think that's really important to hold. And like the other big piece is like, you know, especially when it comes to young people, you know, I would say I'm like we teach them everything else, and then when it comes to relationships, we're like, okay, go ahead, figure it out, trial and error.
Yeah, yeah.
Good luck, you know. Yeah, yeah,
I'm not a victim
yeah.
Mhm.
No,
from
Absolutely.
from that happening at such a young age and being conscious that it's totally wrong.
yeah.
It felt so
But you can't help but like be in it. Yeah, yeah.
there's no way that
No.
I'm not winning the rounds when it comes to this.
Yeah,
Correct.
yeah.
That's all I'm saying. But not everyone is in that
Correct.
to be smart and it's a lot of moving parts.
Moving parts. Yeah, no, I
And
think
it's not one size that fits all. Situations are all
I-
different. So
And I think like Marlon was saying, these are two experiences, two sides of the same coin, right? When we
Yes.
say hurt people, that's
Yes.
they're there
Mhm.
for a reason.
I totally agree.
And we kind of, you know, it's neither of them are who we are. We've all been harmed. We've all harmed somebody.
Mhm.
Period. I
Period.
guarantee you, everybody in this
Full-
room.
Yes.
Like, and so even talking about them as these like discrete experiences of who's a victim, who's not, is not always helpful because
Yes.
that's not how you experience it in your life necessarily. And I do think I will make a point of like, you know, I think the healthy relationship education piece, starting early and keeping it going like all through school. Like we're focused, you know, we have a relationship abuse prevention program in middle schools and high schools, and that's what it focuses on, right? What does consent look like? How do you say no to a friend? How do you hear no from a friend, right? Because I feel like that's the other big missing piece in all of this is giving people the tools to have healthier relationships and navigate conflict in a way that feels safe because that's where so much of this comes from, right?
Absolutely. I had hoped that we might be able to get one last question, but I know that we have some folks outside who are anxious to be a part of the photo shoot. So I really want to thank you all for being here, Dr. Data, Marlon, and Commissioner. Thank you to our online folks who are here. Thank you to those of you who are here in person. It's given us a lot of thought for things that we'd never thought about. Strangulation has never had crossed my mind. And the impact of what it potentially can do, not just in the moment, but further down the line. So there are things that we are aware of now, certainly that we were not before. I do encourage you to help others to provide access to resources. We have a wealth of resources here, starting with Nicole and with Zepeda and also with Inspector Haynes. So please, if you know anyone who needs support, please reach out to them so they can help guide you as well. Now, if you'll give us a couple of moments to take a few pictures, and if you'll join us outside for the photo shoot, I promise you there's a purple t-shirt for you. But you can only get the t-shirt if you're there for the picture. All right, first come, first serve. So if you, where is Marcos? Can you grab Marcos for me, please? Thanks.